case of remission and exacerbations. It is considered an autoimmune disease, and the immune system is affected. So as far as incidence prevalence, the peak onset is 20 and 50. Women 3 times more than males. They really don't know the exact cause of why this happens. They think it's an autoimmune response of the nervous system, possible genetic factors, a bacteria or a virus could trigger the autoimmune response. So you can see the symptoms affect the CNS, the optic nerves, the brain, the spinal cord. As far as the environment, obesity, lack of vitamin D exposure, so you have, certain geographic locations that don't have sun, maybe they get sun 1 month out of 12. So, there's no vitamin D exposure there. High salt diet in teen years. So, and many people did not put snow peaks of salt on their french fries when they were 15, 17, everybody, right? Because you have to have that sort. Here's another little picture that can, can help you there. Yes, God bless you. So collaborative management, assessment. So your common signs and symptoms, you have fatigue, depression, weakness, diplopia, numbness, pain, spasticity, difficulty coordinating, and loss of balance. Your manifestations, your vision, you develop a lesion in the optic nerve, and you can have diplopia. Scotomas, this little white patchy thing, that's a scotoma. It's called patchy blindness. You get white spots in the visual field. Eventually, that leads to total blindness. Always when you have patients like this, you always have to check the visual acuity if the patient starts complaining about their eyesight or their vision, okay? And then, of course, there's the eye patch, as you can see with him. Fatigue, again, fatigue is the most disabling symptom. Heat, anemia, depression, certain medications, they can all contribute to fatigue. We want them to avoid hot temperatures. We get treatment for their depression. Perhaps maybe they have to have a change in meds. OT, PT, that also can help manage the fatigue. Decreasing the use of electronic devices before you go to sleep. That actually can improve sleep quality and lessen fatigue. Because if you think about it, if you're on a phone or an iPad or on a computer, and you're on it for a couple of hours, and then you go to sleep, when you actually, this has happened to me, when you actually close your eyes, you can sort of see the screen their screen that you were looking for. Especially if you're playing like a game or something, you're amusing yourself, so you think that you're relaxing. You're having a nice time in your head, but your brain is not enjoying that, because now your brain is seeing everything that, anybody else have this, or is it just me?
Yeah.
Okay. So, it becomes like a thing, so you learn to let that go like about a half hour before you think you're gonna go to bed, so that when you do close your eyes, you're seeing dark. You're not seeing Pac-Man running around. Okay, sensation changes, pain, paresthesia, proprioception loss. So perimenopausal females with MS, they have pain related to osteoporosis. So these patients, it's always recommended they get bone mineral density testing to see if they have osteopenia, osteoporosis, what is it that they have, if they have anything. Usually they do. Spasticity, as far as spasticity, mostly it's in the lower extremities. Cognitive problems, if the problem is in the frontal or the parietal lobe, they can have some degree of memory loss or decreased concentration. Dysphagia, difficulty swallowing, so we always check for the correct food, the liquid consistency, and always suction set up at the bedside. And we know when you're feeding any patient that has a problem, any patient, upright in a chair. speech language pathologist, again, is gonna evaluate speech and swallowing. Difficulty coordinating, they have ataxia and a tremor, so very easy with that gait disturbance, they can lose their balance. Bowel and bladder dysfunction, and sexual dysfunction, so we always assess for a neurogenic distension, that bladder distension, and how do you assess for that? You palpate, right? You palpate the bladder to see if we have any kind of bulging there. So, you're assessing for the bladder, those patients have an increase of a UTI, so of course, you're always assessing for increased temp. Remember, in anything we talk about, when you see an increased temp on any of these patients, it's always the priority patient, always priority, okay? You have a bedpan or a urinal readily available. We instruct the patient, drink measured amounts of fluid every 2 hours. We want them to void like 30 minutes after they drink, okay? Encourage them to take prescribed meds, the prescribed med for spasms. What are some of the medications that you take for spasms? Nobody remembers? No? Okay. And you want to teach intermediate self-catheterization if it's needed, only if it's needed. Sexual dysfunction, nerve damage, psychological reaction. You should actually plan when you're going to have sex when the patient's not fatigued, okay? And if it becomes more and more difficult, then you explore alternate methods. Males, they can have erectile and ejaculatory disorders. Of course, that will affect their self-esteem. Females, orgasmic dysfunction. They get muscle spasms in the thighs. So intercourse becomes very difficult, and at one point it actually becomes impossible, okay? Again, you can only speak to the little parts that you can speak to. You get a sexual counselor to speak with the patient and the partner. So what are the factors that aggravate or trigger MS? So we said stress, extreme fatigue, overexertion, temperature extremes. Diagnostics, you have MRI, EEG, a CT, and then of course you take a sexual history. So, common symptoms that require intervention. So remember, for each symptom we always have an intervention. So you have ataxia, you have bladder dysfunction, depression, fatigue, spasticity, diplopia, numbness, and pain. So what drugs are we going to use? We're going to use the BRMs, the biological response modifiers. Remember, biological modifiers modify the course of the disease, right? So we want to start those early. We want to decrease the number and the frequency of relapses. We want to decrease the size of the plaques that you see on that MRI. So BRM's first line of treatment, okay? So interferon beta 1A, which is Rebif, and interferon 1B, which is betaseron. Those are given sub-Q every other day. So there's a whole lot of the interferon, so don't get nuts. So interferon beta 1A, that's a whole different preparation. The first two, they're combined. They combine that drug into one shot, right? This is a separate shot altogether, all by itself. So this interferon beta 1A is called Avonex. Completely different preparation. And it's given once a week IM. What is important is that the side effect of all these interferon drugs, as many in the world that they all have the same exact side effect. They have flu-like symptoms, okay? And you manage it with acetaminophen, okay? So it'll last a few months and then it's gone. Another drug that's used is glatiramer acetate, and that one is administered sub-Q every day. The side effect there is injection site reaction and flushing. It is self-limiting to just a few minutes. You get that flush, and you may have some redness at the injection site. We have to teach the patient how to draw up the med and how to self-administer the sub-Q, right? So this is demonstration, return demonstration. Anytime you're sending anybody home with any kind of sub-Q or anything else, it's demonstration, return. They can't go home unless we see that they can do it. And then who makes sure they're doing it right? Who?
No.
The nurse.
What nurse? I said when they go home.
Oh,
At home care nurse,
Yeah.
you keep talking about, right? She'll watch the patient to make sure that the injection is being given correctly as well. And if it's not correct, whatever the patient is not doing right. Okay. Another drug is fingolimod, PO. It's an alternative to the sub-Q glatiramer, and as you see, it says the patient can have an injection site reaction. If the patient has a couple of reactions, they're not going to keep the patient on the med. So they'll give this, it's PO. Okay, so it's the alternative. Steroid therapy, IV methylprednisone, that's the key medication in treating acute exacerbations. It shortens that relapse period, but there is no long-term benefit to that.
So they won't take that one? It's just a short term thing?
If they need it. Okay. Spasticity, so these are symptomatic, so spasticity. You remember we talked about baclofen, and we talked about dantrolene, anybody remember that? Were you awake for that? Yeah? Okay. We talked about baclofen, we talked about dantrolene, we talked about oxybutynin, if you remember, right? We were talking about bladder just the other day. So baclofen here is the medication of choice. So it can be given PO, or it can be given intrathecal, and it decreases the muscle spasm, okay? So the patient should have improved ROM in all their extremities with this medication. We're going to monitor for drowsiness, so these patients should not be driving a car or working in construction or anything like that. Dantrolene is another antispasmodic. With dantrolene, you have to remember to wear sunscreen. It makes the skin very sensitive to the sun. Other meds, we have the benzodiazepines, like diazepam, that also can be used for spasticity. So the goal here, the patient's going to have improved ROM in all the extremities. So fatigue, we know fatigue interferes with the ADLs. So the drug of choice is amantadine. You can give Pemelin as well, but amantadine is more frequently used. Ataxia is a chronic problem. If it's resistant to treatment, they can give propanolol, which is a beta blocker, they can give gabapentin, or they can give clonazepam, any of those three. And you have your drug list in front, am I correct?
Yeah.
So as far as nursing management, again, there is no cure. So we want to promote physical mobility, we want to avoid any kind of falls, we want to decrease fatigue, we want to develop coping strategies, and absence of complications. So, physical mobility. Decreased strength is very significant in multiple sclerosis. So, we want to help the patient to perform ROM exercises every 8 hours. Walking actually improves gait. So we want to teach the importance of daily exercise, the use of assistive devices if they need it. Remember, safety is always first. We don't want them to fall. Teach the patient to walk with a widened gait for better stability, okay? Again, risk for falls. Place the call bell close to the patient. They don't have to stretch. PT, OT may also be needed. Spasticity and contractures. So this is common, including later stages, and it's characterized by spasm of the hips and the knees. So we're going to apply warm pack to the area, but no hot bath. Remember, no temperature extreme. No hot, no cold. Okay? So warm, tepid, warm. They can burn themselves. They have decreased sensory. They'll just step right into the water. Okay? They can get a second-degree burn. Exposure to extreme cold, avoid it. Daily exercise prescribed, yes, we don't want them to form contraction. Activity and rest, you want to encourage that patient to work and exercise just short of fatigue. Of course, we don't want them to do strenuous exercise. We know that they're going to get tired, so what do we say from the beginning? You do something, you rest. Short rest period, you do it again. That's how they balance, and that's how they don't wind up in the hospital. Heat, why not heat? It decreases the fatigue and the muscle weakness, okay? So if possible, air conditioning in one room. If you can get it in more, that's fine, but at least one room where, like, in the summer when it's 90 degrees and the house is hot, and sometimes you have fans, and the fans just blowing hot air around, it doesn't really cool. So if the patient can, just one air conditioner.
But not in the same room with that air conditioner, a separate room, right?
No, they can, whichever the room the patient spends the most time.
Oh, they can have the air conditioner.
Yeah, oh yeah. Someplace where the patient can go to get cool.
Okay. Because I thought they weren't allowed to be extremely cold.
No, you can put an air conditioner on like 72, 75. You don't have to have an air conditioner on 60 or 62 like the old ones.
Yeah, that's what I was thinking,
When it's 98 out. No, 72, 74, it's comfortable, but you're not sweating.
And sweating, okay.
Okay, nutrition, healthy diet, so weight reduction. Make sure you include the family members when you're educating about nutrition. This patient needs a high fluid, high fiber diet. We want to prevent any kind of constipation, avoid alcohol and smoking. You don't want anybody to get constipated anywhere, right? Ever, in any food. As far as strengthening the coping mechanisms, so you can read that, you know it already. Home and community, you can read that, you know that as well. Look at the bottom, independence as much as possible. That's the goal. Completing the ADLs without fatigue, those kinds of things. Those are your goals. And these are your priority problems. Impaired physical mobility because of muscle weakness, spasticity, increased weight, unsteady gait. Risk for injury, they have the visual and the sensory impairment, impaired bowel and bladder. They have that neurogenic bladder, verbal, aspiration, blah, 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 blah. Okay? Your resources, MS Society and Meals on Wheels. Any questions on this? Can you see similarities?